Okay. Good evening, everybody. So, welcome to this, weekly webinar by CCI. So, thank you, CCI, especially Dr. Bijay sir, Dr. Uttri, for giving me opportunity to moderate the session. So, today's topic would be on, CPR in 2025 and the Lazarus syndrome. And tomorrow is very important and special day for us because in Kolkata, basically CCICon 2025 is starting. Welcome everybody in Kolkata. A heavy rain is going on, but still a warmful welcome to everyone. So now we have an extreme panelist of, esteemed panelist for this webinar. So first, Dr. Abhishek Tandon, he is a consultant from Medanta Hospital, Lucknow. Then Dr. Moitreyee Kalita, who is from Downtown Hospital, Guwahati. And we have also Dr. Ruby Joseph K, who is a consultant in Astra CMI Hospital, Bengaluru. And also welcome Dr. Tejasvi sir, Tejasvi Chikatla. He is consultant emergency physician in Apollo Hospital, Hyderabad. And last but not the least, Dr. Vibhu, very welcome. And he's from Vibhu Nursing Home, Delhi. Okay, so so there will be two presentations back to back. So first one by Dr. Tejasvi on CPR in 2025, the BLS SLS protocols, and the next talk would be on the Lazarus phenomenon by Dr. Abhishek Tandon. Okay, so welcome, Dr. Tejasvi. Please start your presentation.
Hello all, I'm Dr. Tejasvi, consultant emergency physician at Apollo Hospitals, Hyderabad. I'm also training center faculty for American Heart Association, instructor for ATLS, simulation and focus, and I'm a master trainer for basic emergency care WHO. First of all, I would like to thank CCI and Dr. Arnab and Dr. C. Vijay Kumar for giving me this opportunity to talk in this webinar. I'm going to talk on basic life support and advanced cardiac life support and the importance of CPR. Why CPR is important? Because time is gold, time is critical. So our brain damage eventually happens after the cardiac arrest. So to protect the brain, so we need to intervene immediately, and this early CPR is most important. First 0 to 1 minute, a cardiac irritability will start. At 0 to 4 minutes, the brain damage not likely. At 4 to 6 minutes, the brain damage possible. At 6 to 10 minutes, the brain damage very likely, and more than 10 minutes, irreversible brain damage happens. To start with, the adult chain of survival, which is the most important aspect we should know when we're doing the resuscitation. In in-hospital cardiac arrest, the chain of survival would be the early recognition and the prevention, the activation of emergency response system, which is most important, the high-quality CPR, the adequate compression should be there, the defibrillation, the early defibrillation for the shockable rhythm is most appropriate, the post-cardiac arrest care, the post-TROS, the care, what we need to ensure that will be most appropriate, and the post-recovery, okay? Early activation of emergency response, high-quality CPR, defibrillation, advanced resuscitation, and post-arrest care, and the recovery. The difference between the in-hospital and out-of-hospital is the out-of-hospital, the arrival of advanced cardiac life support team and the advanced resuscitation team is most important aspect to take over the resuscitation from the layman. The advanced basic life support, whereas in-hospital or out-of-hospital, first we need to ensure the scene safety, then we need to check for the response, short for any nearby help, activate emergency response system via mobile device or a call nearby help, get an AED and emergency equipment at the earliest. Then we need to look for the pulse and the breathing simultaneously for not more than 10 seconds, not less than 5 seconds. If the patient is breathing normally and the pulse present, you need to just monitor for emergency care. Then if the person is not breathing but pulse present, then you need to give one breath every 6 seconds or 10 breaths per minute. If the person is not breathing or only gasping and pulse not present, then you're going to start the CPR immediately, like 30 compressions and 2 ventilation breaths. And you need to attach the AED or a defibrillator at the earliest. When you attach the AED, it is a smart machine. What you need to do is just on the AED, it will give us prompts. It will give us prompts like analyzing the heart rhythm, do not touch the patient. So what it does is it analyzes the rhythm, whether it is shockable or non-shockable. If it's a shockable rhythm, it says shock advised. Then we need to ensure everyone is safe, clear the, no one is touching the patient, and we need to deliver shock, followed by immediately we need to start the chest compressions. We need to continue this chest compressions, and every 2 minutes we need to analyze the heart rhythm again. We need to analyze the AED here. In case of defibrillators attached, we need to analyze the defibrillator rhythm. If it's in case of non-shockable rhythm, we're going to continue the chest compressions continuously. That is 30 to 2 chest compressions need to be given here. In case of there's an advanced airway like endotracheal tube or a tracheostomy tube is in situ, then you need to give one breath every 6 seconds, and followed by chest compressions should not be interrupted unless the chest compressions only interrupted at the end of 2 minutes for analyzing the rhythm and checking for the pulse. The criteria for effective CPR, that is push hard, push fast. We need to deliver at least 100 to 120 compressions per minute. The rate should be at least 100 to 120 compressions. Then 30 to 30 compressions and 2 rescue breaths or a ventilation need to be given. We need to minimize the interruptions for the CPR. We need to push at a depth of at least 5 to 6 centimeters or 2 inches. Allow chest, recoil completely. Airway maneuvers, after 30 compressions, if there's no advanced airway initiative, you need to head till chin lift and give rescue breaths. But it should not be done in case of trauma like road traffic accidents, fall from heights, injury to head or neck. In such scenarios, we use jaw thrust maneuver. Next, we're going to talk on, then once the basic life support is finished, it is taken over by the advanced cardiac life support team. So when you take over advanced life support team, then to connect to the monitor, check for the shockable rhythms or non-shockable rhythms. That is, it is connected to the defibrillator. When you connect defibrillator, we need to see it is shockable rhythm, that is pulseless VT or a VF, or a non-shockable rhythm, that is pulseless electrical activity or a asystole. These are the shockable rhythms. This is the VT with pulse, and this is ventricular fibrillation. VT is nothing but ventricular tachycardia, and VF is nothing but ventricular fibrillation. Ventricular fibrillation is always without pulse. These are the non-shockable rhythms, asystole, and the pulseless electrical activity. There is some electrical activity, but there is no pulse. Such rhythm is called pulseless electrical activity. We need to follow the AHI algorithm. As soon as you check the rhythm, patient is unresponsive, no pulse, and the rhythms, you need to check for the rhythm as well. So we need to start CPR immediately. While checking the rhythm, you need to stop the CPR, analyze the rhythm. If the rhythm is shockable, we need to deliver shock immediately. Then resume CPR for another 2 minutes. Meanwhile, you need to secure an IV access. After 2 minutes, you need to check for the rhythm again. When you're checking for the rhythm, we need to do 3 things. First, stop the chest compressions, check for pulse, and analyze the heart rhythm on the monitor. If the second rhythm is also a shockable rhythm, we're going to deliver one more shock, second shock, then resume CPR for another 2 minutes. Here, we're going to deliver the first drug, that is epinephrine or adrenaline 1 mg. Then we need to continue CPR for another 2 minutes. Then after 2 minutes, we're going to analyze the rhythm again and check for the pulse. We'll stop the compressions, and we want to ensure that we have to change the compressors so that they not get fatigued. After the third cycle, we need to recheck again. Then if there's shockable rhythm again, we need to deliver one more shock. After shock, we need to resume the chest compressions again. Here, we're going to deliver the amiodarone or a lidocaine. Amiodarone, we should give around 300 mg, or a lidocaine, it is 1 mg per kg. Here, we should think about reversible causes. The reversible causes will be 5Hs and 5Ts. Then after the 5th shock, we're going to give amiodarone 150 mg. Then when it comes to the non-shockable rhythm, that is asystole or PEA, here we need to give immediately the epinephrine 1 mg IV start, and for chest compressions need to be continued for 2 minutes. Every 2 minutes, whether it's shockable or non-shockable, you need to analyze the rhythm, stop compressors. When you're analyzing the rhythm, you need to stop the compressors, and you're going to check for the pulse, and also ensure you need to switch roles of the compressors. Okay. And here, adrenaline will be given every 3 to 5 minutes. And this cycle keeps continuing until you attain a ROSC, or you're going to realize that you're going to stop the resuscitation. Then CPR quality, the CPR quality should be push sharp, push fast, at least 100 to 120 compressions per minute, at least depth of 5 centimeters. The minimization of chest compressions, we should not interrupt the chest compressions very frequently, as reduction of compression rate should be appropriate. The reduction time should be very less. The chest compressions are most important aspects during this cardiac arrest resuscitation. Then, if no advanced airway is there, you need to give chest compressions of 30:2 compression and ventilation ratio. And we need to connect to the waveform capnography to assess depth of the compressions and also to ensure advanced airway in situ. Then, the shock delivery should be the biphasic, you need to give about 200 joules, and the monophasic, you need to give about 360 joules. In case if you defibrillate is biphasic or a monophasic. The drug are used are the epinephrine, amiodarone, and the levodopa. Advanced airway, if it's not done, you can do the advanced airway during resuscitation, or else you can just do the bag mask ventilation. And once you've done the advanced airway in situ, like endotracheal intubation or a supraglottic advanced airway, you need to connect to the waveform capnography and check and confirm ED tube placement. Once advanced airway is in situ, your breath rate will be 1 breath every 6 seconds. Here, you will continue the chest compressions for 2 minutes. You will not interrupt chest compressions for breaths. The breaths will be given simultaneously for every 6 seconds. Once you attend the ROSC, how you will identify? You will check the pulse, whether the pulse is present or not. And you'll also check for the EtCO2, whether its abrupt increase is there or not. You'll also check the arterial pressure waves if the intra-arterial monitoring is happening. Then your reversible causes, that is 5Ts and 5Ts, the hypovolemia, hypoxia, hydrogen ions, hyperkalemia, hypothermia. And 5Ts, your tension pneumothorax, cardiac tamponade, toxins, pulmonary thrombus, and coronary thrombus. And once you assume that there's a pulse has attained, so you got return of spontaneous circulation. There should be an organized rhythm and the pulse present, that is, your return of spontaneous circulation is identified. Once you identify return of spontaneous circulation, what you need to do is, you need to assess A, B, C, D, E. That is, first, you need to manage the airway. If endotracheal intubation is not done, you can do the endotracheal intubation here, and you can monitor saturations 90 to 98%, start the respirator at around 10 breaths per minute, and maintain PaCO2 of 35 to 40 millimeters of mercury. Then you manage hemodynamic parameters, that is, maintain systolic blood pressure more than 90, mean arterial pressure more than 65. If in case your blood pressure is lower, you need to secure up to white bore lines, collect samples like blood grouping cross-matching, your complete blood picture, and a blood gas. Here you need to start an IV fluids, that is 1 liter cold crystallites. And you need to obtain 12-lead ECG. Consider for the emergency cardiac interventions, only it is required when there's a ECG showed ST elevation MI. So if ST elevation MI is there, you need to plan for cath lab, immediately inform cardiologist, alert cath lab, and shift patient to the cath lab for primary coronary intervention. If the patient ECG showed non-ST MI, there's no MI, then you need to consider shifting patient to the cath lab. Then when you're during disability, you follow commands. If the patient is awake, just shift the patient to the critical care and do the further management. If the patient is not following commands, you need to do endotracheal intubation, manage targeted temperature management, obtain brain CT, EEG monitoring, and other parameters. And also, here you need to consider reversible causes again and treat the reversible causes which are allowed the patient to go into the cardiac arrest. So reversible causes treatment is most appropriate and mandatory here. Team dynamics. The team dynamics is most important aspect during the resuscitation. The good team dynamics will allow good resuscitation and decreases the mortality and morbidity of the patient. So what is required, how to communicate, and what to communicate and when to communicate. And also what the roles and responsibilities of each individual should be appropriately assigned. The close loop communication with clear messages is important. And the knowledge sharing and constructive interventions during resuscitation is very ample. And the mutual respect between each individual is important. Knowing the limitations is very appropriate. And when to terminate the resuscitation? When the resuscitation, the cardiac arrest is not witnessed, there's no bystander during CPR, there's no return of spontaneous circulation, no shock was delivered before transport. If all criteria is present, then you can consider termination of resuscitation. If any criteria are missing, continue resuscitation and transport. Thank you.
Thank you, Dr. Bera, for the kind introduction. At the very onset, I would like to thank CCI for giving me this opportunity to be present amongst all of you for this very interesting and important webinar on CPCR and Lazarus phenomena. So the topic that has been given to me today is a deliberation on Lazarus phenomena. So what is Lazarus phenomena? Autoresuscitation or Lazarus phenomena is a phenomena of the heart during which it can resume its spontaneous activity and generate circulation. It was described for the first time by Linko in 1982 as a recovery after discontinued CPR. It was G.J. Berry who named it the Lazarus phenomena in the year 1993. It is based on a biblical story of Jesus' resuscitation of Lazarus 4 days after confirmation of his death. And this is how we get the name of Lazarus phenomena. Now, all of you who are listening to this webinar here today have this question in their mind. Is this true? Do we have any reported cases? And you'll be surprised to know that up until the end of 2022, there were 76 cases coming from 27 countries of spontaneous recovery after death. Among them, 10 were children. The youngest patient was as young as 9 months old, and the oldest was a 97-year-old man. The longest resuscitation lasted 90 minutes, and the shortest was somewhere around 6 minutes. Now, why is this Lazarus phenomena happening? What might be the cause? Now, based upon the available publications, I went into the details of all the cases that were reported. There were various factors which were hypothesized to be the cause. But the most logical one and the one that has been most widely reported is a delayed drug action. So what basically happens is while you're performing CPR, you administer certain drugs, the action of which might start late because you're not delivering it through a central venous catheter, you are delivering it through a peripheral line. And by the time it reaches the circulation, you've almost always stopped the process of CPR. The drugs then hit and the resuscitation happens. So this is the most plausible explanation which I could have had found over the data that had been there on the internet for the Lazarus phenomena. Now, a very pertinent question which should come to our mind is it then negligence to pronounce a patient dead? For this, I would want to take you to a case report. So, a 65-year-old male from Japan suffered a sudden cardiac arrest. Asystole was confirmed and resuscitation was performed for 35 minutes. After the procedure, the patient's remains were moved to the hospital mortuary. Later that day, a police officer arrived at the hospital mortuary to perform post-mortem procedures, and he found that the patient was slightly moving and showing vital signs. He immediately called for the doctor, who confirmed agonal breathing and observed sinus rhythm in the ECG. Now, the death of the patient was clearly confirmed by the same doctor 20 minutes earlier. The patient was immediately transported to the hospital ward but did not regain consciousness. On the 5th day, his condition deteriorated significantly and he eventually, sadly, passed away. This case of the patient is cited in medical literature as that of negligence caused by premature termination of resuscitation proceedings and subsequent transfer of the deceased for post-mortem examination. This is not something which is new to our country as well. Many a times you hear the media shouting that a patient has been pronounced dead in the hospital, but when the patient reaches home or the dead body reaches home, it shows sign of life. And when I was searching for literature of Lazarus syndrome in India, I found this newspaper article as early as last month, wherein Bede, a newborn declared dead was found to be alive 24 hours later, and it was Lazarus syndrome indeed, which was attributed for this particular condition. Now, this again brings us to a very important question. If phenomena such as auto-resuscitation exist, how long do we wait after a resuscitation before pronouncing a patient as being dead? So medical literature tells us that a Turkish patient, after undergoing CPR, was observed for almost 3 hours post CPR and underwent this phenomena, the Lazarus phenomena, after 3 hours, showed signs of life, beg your pardon. Many a times, and we'll also be discussing it during the panel discussion subsequently, as to many guidelines now come, many societies now recommend that we need to monitor a patient post CPR for a pre-specified duration of time before actually pronouncing the time of death. Now, why are we discussing it here today? Lazarus phenomena has both an impact on medical practice and a psychological impact. On the medical practice aspect, the phenomena raises questions about the definition of death, the timing of pronouncements of death, and the need for extended monitoring after CPR. Psychologically, Lazarus syndrome can be distressing for both medical staff and families, highlighting the need for support and counseling. And we'll be discussing more of this in the panel discussion today. This brings me to the last slide of today, and I would now request Dr. Bera to take it forward from here. Thank you so much.
So welcome back. So excellent presentation by Dr. Tandon and Dr. Tejasvi. Now we quickly move to our main part of this, this webinar, that is the panel discussion of CPR. So my first question would be to Dr. Abhishek Tandon. Dr. Tandon, are you online?
Yes, sir.
Okay, great. So I heard you. This excellent talk, Dr. Tandon, by you. So now just tell me briefly. So what is this CPR and why it is so clinically important? Why you are talking this talk about this webinar about? Okay.
It's a very important question, Dr. Bera. So CPR stands for cardiopulmonary resuscitation. And I firmly believe that it is a basic life hack which should not only be known by all of the medical practitioners, but should be taught even at such basics as that of school. Imagine you're sitting at an airport with a friend and the friend suddenly collapses. There's no facility of a hospital nearby. What do you do till medical help arrives? There is a facility that is being available with you where you can temporarily, many a times it's a permanent solution as well, but most often than not temporarily, keep the patient alive while pumping onto the chest, ensuring that the circulation is in place and ensuring that the patient actually reaches the medical facility in a state where once revived, once the patient achieves spontaneous circulation, can then be salvageable. But unfortunately, given the state of affairs in our country, a survey recently told us that as many as 40% of the Indian practitioners, healthcare practitioners, are not even well versed with the basics of a CPR. So this is what it is. And yes, it's very relevant as far as our medical practices is concerned, because this is an emergency situation by which you can actually revive a patient who collapses in front of you.
Yeah. Excellent. Thank you, Dr. Tandon. So my next question would be to Dr. Moitreyee. So it is already discussed in the webinar, but still, you tell me the most common reversible causes of cardiac arrest. And there are two terms, the CPR and CPCR. So is it something different or the same? Dr. Moitreyee?
The most common causes of cardiac arrest that we encounter can be broadly divided into cardiac causes and pulmonary causes. So among cardiac causes, most common is any patient with coronary artery disease. The sad part of which is that coronary artery disease many a times goes unnoticed or it remains undiagnosed till an attack of MI comes up. Am I audible, sir?
Yes. Clear and loud.
So, and sometimes we may also have ischemia-induced arrhythmias in a patient with coronary artery disease. Then there are the cardiomyopathies. like DCMP, HOCM, and arrhythmogenic RBCM, right ventricular. We have heart failures, especially those with low ejection fraction, in primary electrical disorders or channelopathies, like we call them, and valvular heart disease, especially aortic stenosis and mitral prolapse. Now, many patients in our country are not very keen on having, most of them are, but not many are keen on having echocardiogram. So, most of these diseases present as a cardiac arrest.
Okay.
Unfortunately. And coming to pulmonary and respiratory causes, we have causes of like severe hypoxia, advanced COPD, or an asthma exacerbation. Like, most obstructive airway disease patients are treatment naive. They're not on any treatment, so they may present with sudden hypoxia. Pneumonia, especially ARDS, especially after the post COVID era. ARDS is so common. And apneas. Pulmonary embolism being one of the most common sudden causes of cardiac arrest. Tension pneumothorax, which is very, very tricky, easily diagnosable, easily correctable, but then often unnoticed cause of respiratory arrest or cardiac arrest. Aspiration. Aspiration is very common, especially in patients with comorbidities, especially in patients with cerebrovascular problems. Severe hypercapnia, like which causes acidosis, and it interferes with the myocardial contractility at many levels. And the respiratory failure of any cause because of long-standing interstitial lung diseases, other systemic diseases, and neuromuscular diseases, etc. Now, coming to the difference between cardiopulmonary resuscitation and cardiopulmonary cerebral resuscitation. Essentially, we are all talking about resuscitating an individual, right? Bringing him back from a state of absent circulation. But when we talk about cardiopulmonary, we are concentrating entirely on circulation and breathing. Sometimes after a successful CPR also, sometimes we often see that the irreversible brain damage has been done. When we include cerebral in the term, we are also emphasizing on adequate perfusion to the cerebral circulation so that we can minimize the damage done to the brain. Like the CPR saves the heart, CPCR saves the person. So we can ensure that the functional status of the patient post a successful CPR is also intact when it comes to CPCR. So the number of advanced technical maneuvers that are done to ensure CPCR, an effective CPCR, essentially same but a bit different.
Okay, thank you. So basically for the audience, Dr. Tejasvi has given a 5 mnemonics. That is, you have to remember this 5H and 5T for the reversible cause of cardiac arrest. That is hypoxia, hyper or hyperkalemia, excess hydrogen ion, hypovolemia, hypothermia, and for the T's are pneumothorax, tamponade, toxins, thrombosis, coronary or pulmonary. And regarding this, the CPCR, these all both are essentially same as you said, and that is the important part is that is also discussed by I think Dr. Tejasvi, that more than 10-second delay in the circulation that can cause irreversible brain damage. Okay, so now my question would be to Dr. Ruby Joseph K. So what is the importance of this standard CPR, and what do you mean by high performance CPR? What is the basic criteria for high performance CPR? Dr. Ruby.
Yeah, thank you, Dr. Bera, and thank you, CCI, for this opportunity. So, bystander CPR is basically a cardiopulmonary resuscitation performed by someone who is not a part of the standard emergency response system. So, it's a very crucial intervention for out-of-hospital cardiac arrest. Potentially, it doubles or triples the victim's chance of survival. So, it's been noted that the bystander CPR rates worldwide is around just 20%. And bystander CPR involves chest compression and, if available, using an automated external defibrillator. So they need to initiate a bystander CPR when you see someone who is unresponsive and not breathing or just gasping. The reason why this is important is more often there is a fear of causing harm. So that shouldn't prevent someone from performing a CPR because the potential benefits outweighs the risks. So in short, bystander CPR would be empowering ordinary people to become lifesavers in a critical condition. Now, coming to what is a high quality CPR, it involves performing chest compressions with the correct rate, correct depth, and allowing a full chest recoil while minimizing the interruptions and avoiding excess ventilation. To tell it in short, the compression rate that needs to be given when we, after we check the carotid pulse, like the previous speakers have mentioned, we check the carotid pulse for 10 seconds, no pulse, start CPR. So you use the heel of one hand on the lower part of the sternum in the middle of the chest and put the other hand on top of the first hand. Straighten your arms, don't lean on the patient. This is important because the compression rate that you have to maintain is 100 to 120 compressions per minute.
Yes.
So push hard and push fast is the rule. Compression depth should be, in adults, it should be 2-inch deep. For children, 2-inch deep, and for infants, it's around 1.5-inch deep. Most importantly, you should allow the chest for recoiling. So after each compression, allow the chest to fully recoil. This is to allow blood to flow back into the heart. Because if we do it without allowing the recoil, it becomes a failed CPR then. And again, avoid leaning on the chest between the compressions because this can restrict the blood flow. So mostly if you're getting tired in a CPR, try to switch the persons. Minimize the interruptions between it. So keep the chest compressions going on as much as possible. Interruptions should be minimized to maintain a high chest compression fraction. So what is it? It's the percentage of the time during a CPR that actually you use for chest compressions. So ideally, it should be more than 80%. And minimize excessive ventilation. So for 30 compressions, it should be 2 breaths. And how do you give those breaths? It's with a head tilt and a chin lift and head tilt. But if you're suspecting a neck injury, so you should give a jaw thrust. So this is in short about
excellent.
a high quality.
You have covered all the points, Ruby. Thank you. Now I will move to Dr. Tejasvi. So what is the basic difference between in and out of hospital cardiac arrest management protocol? Dr. Tejasvi.
Thank you, Dr. Arnab. I think a wonderful question. As in India, most of the layman people, the non-medical practitioners, the CPR training is not adequate. So that's the reason it's important to know the out of hospital and in-hospital cardiac arrest. In hospital, it's healthcare professionals who are trained in the BLS, who are trained in the ACLS, where the quick treatment happens. The chance of survival is much higher when compared to out of hospital. The main differences is like the resource, the equipment availability is much higher in the hospital, but out of hospital is not available. And more important, the person who is doing a CPR, who should be trained, but who is not trained in the out of hospital, again, the chance of survival goes down. But the person who is trained, giving a CPR and activation emergency response system at the earliest will give a better fetch in the out of hospital CPR. In hospital, it's immediate activation, immediate intervention, resource availability. Thank you.
Okay, thank you. Thank you. Short and crisp. Okay. Now, Dr. Vibhu, please. So we have learned so many things about, this adult CPR. So what is the basic difference, or is there any kind of difference between, adult and pediatric CPR? Dr. Vibhu?
Yeah, thank you, Dr. Arnab. There's not much of a difference, except that in case of a child or in case of an infant, the compression to the breath ratio, if you have 2 rescuers, is 15:2 instead of 30:2. Another point is that the pediatric cardiac arrests are often due to respiratory failure. So effective rescue breathing is very, very important and is crucial. And another thing is there that you don't need to press too hard or too fast, but still maintain an adequate compression depth and recoil. So now the point is that how much we press, because in adults it's quite defined, you need to do this much, but in infants and children you have to be considerate, and it's quite an individualized kind of compression which you need to do. But again, as I mentioned here, more than compression, it's basically the respiration which needs to be taken into account as far as the children and infants are concerned.
Okay. Thank you, doctor. So again, I'll go to Dr. Abhishek Tandon. There is some automated CPR machines. Okay, so is it better than the manual CPR? Dr. Abhishek Tandon?
Thank you for the question, sir. So as far as data tells us, there's actually no difference in the survival outcomes when you use an automated machine over a good quality manual CPR. But the word here which needs to be taken into consideration is a good quality manual CPR. So both have their pros and cons. So like, for example, if you're transporting a patient in an ambulance, you would always prefer that you have an automated machine. If the staff is less, you would always prefer an automated machine. You can ensure that adequate chest compressions of good quality with the same rate and intensity happens with an automated machine, because obviously humans would fatigue. but then in a resource limiting settings, and the cost precludes its availability everywhere. So just to give a crisp answer, a automated machine is as good as a manual, good quality CPR. So that would be the bottom line.
Yes, yes. Sometimes manual CPR is better, I think, some studies. Okay, okay. So good, good. Next, Dr. Moitreyee again. So is there any role of ECMO CPR or eCPR?
Yes, sir. Extra membranous corporeal membrane oxygenation, or eCPR, is useful in certain selected cases with refractory CPR, in which normal CPR has failed, but there is a reversible cause, and ECMO allows us to buy some time to preserve prolonged oxygenation and sustain circulation, and it's a last line advanced resuscitative technique. So it gives us time and maintains adequate perfusion to the cerebral circulation, so that we can concentrate on the other reversible causes and ensure that there is a more successful recovery after the CPR.
Yes, yes.
So yes, but in only certain selected cases. Also, it's a very expensive machine, requires skill. So in certain selected cases of refractory CPR, yes, ECMO does play a role.
Yeah, definitely mainly for the mainly cardiac causes, and preferable when there is in-hospital cardiacs, but sometimes can be done in out-hospital also. But excellent, Dr. Moitreyee. Now, is there any role of EtCO2 in CPR, Dr. Ruby?
Yes, sir. So end-tidal CO2 plays a very crucial role in CPR. It provides a real-time feedback on the effectiveness of the chest compressions and ventilation. So 10 to 20 mmHg is considered as a gray zone or acceptable criteria during a CPR, while a sharp or significant rise after 20 mg is considered return of spontaneous circulation. Whereas assessing the CPR effectiveness, we can do that when EtCO2 is showing up and there is a low or decreasing EtCO2 that may indicate inadequate chest compression, so that the team can make necessary changes in the way they are doing it. And consistently low EtCO2 of less than 10 mmHg after 20 minutes of CPR suggests that there is a low probability of return of spontaneous circulation. So, and other important things is it identifies ROSC and also guides the termination. It's not a final call, but then it guides the termination of resuscitative efforts if it's persistently low EtCO2. Other uses being it helps to confirm proper placement of an ET tube and potential respiratory complications. So definitely it's important in CPR.
Okay, thank you. So I know Dr. Dr. Tejasvi is also POCUS trainer. So we would also like to know from him what is there is any role of POCUS in CPR, Dr. Tejasvi.
I think the POCUS is very upcoming and it's advanced right now, and use of POCUS during resuscitation is very ample and important. It gives to identify the reversible causes during cardiac arrest, and also it helps to differentiate between the true PEA and the pseudo PEA also. And also we need to confirm that cardiac standstill. Like the reversible causes, as we discussed about 5 Ts and 5 Ts, a few reversible will be the tension pneumothorax can be identified with the POCUS. The cardiac tamponade can be identified through POCUS. So when you identify the reversible and you intervene then and there, so the chance of survival will be higher. So use of POCUS is more important, but doesn't mean that you stop the CPR and do the POCUS. You have to do it. Yeah. So the POCUS should happen. The use of ultrasound should happen only. You have a time gap of 10 seconds when you check for the pulse check and the rhythm check. At that point of time, you just put an ultrasound and see for the cardiac and for the lung sign. So that time is more than sufficient and that help us to reduce the time gap between interruptions.
Yes, excellent. So again, Dr. Vibhu, what is SIDS, or the sudden infant death syndrome, or what is called cot death or crib death? Dr. Vibhu, can you throw some light on that?
Yeah, so it's basically an unexpected and an unexplained death of an apparently healthy baby. This is important. It's an apparently healthy baby, and it usually happens during the sleep. And it usually happens in the infants under the age group of 1 year, particularly around 2 to 4 months of age. Now, there has been, several autopsies being conducted, but they have not been able to find any reason as such. There could be the reasons, there are theories that it could be the brain abnormalities, sleep environment, or immature cardiorespiratory control, or even the mother smoking that could be responsible. But per se, there has been no reasons as such which we have seen in case of the SIDS. And one thing I would like to put forward that you've seen more SIDS in the healthy full term babies as compared to the preterm babies. So maybe because in preterm babies we tend to be more cautious with the preterms, so that could be one of the reasons. But as such, we don't really have the thing. And I remember when I was doing my post graduation, I still remember there was this SIDS case which happened in the ward. And the morning, I was standing. I was a first year, so I never knew about the SIDS thing. It was the initial 1 month, and all of a sudden the baby died, and the baby was apparently all right. And it was such a shock for me कि भाई बच्चा बिल्कुल ठीक and everything is fine and it happened. So we had read about it, but looking at it and seeing it is a very difficult and a different experience.
From a doctor point of view and also the parents point of view, it's really shocking, definitely. So now we'll move to Dr. Tandon again. So I'll give you a case scenario, Dr. Abhishek Tandon. So suppose a patient is admitted under you with a pneumonia, and not so sick. You have treated with IV antibiotics, and patient was excellently responded to your antibiotics. Now you are planning for the discharge, and suddenly on the day of discharge, the patient suffered a cardiac arrest, and you don't know why that has happened. The CPR is ongoing, and the patient is not so much responding to CPR. Relatives are agitated, or they want to know what has happened. The patient is going to discharge. How will you handle this situation, Dr. Abhishek Tandon?
Well, Dr. Bera, it's a very difficult situation that you've put me in. But I believe that the essential modes of communication between a caregiver and an attendant should be focused on three principles. The principles are clarity, compassion, and honesty. So first of all, we should have clarity that the patient was apparently doing well and the patient was being planned for a discharge, but somehow a cardiac arrest has been precipitated. We should show compassion towards the attendants. We should answer every query that they put up. We should be listening more and speaking less, and we should be empathetic towards them. And at the end, we should be very honest with them. I know a lot of our medical practitioners are hindrant that what if the patient suspect a foul play, what if they think on the lines of negligence. But if you are honest and if you are clear with your thoughts, I think with compassion and empathy, if communication is done well, anything and anything can be tackled. So this is what my take would be.
Excellent. Definitely, you have to go by that way. And even every time a patient admitted under you, so something is definitely wrong with the patient. That's why the patient is admitted under you. And
Absolutely.
I never tell any time that your patient is so good, your patient is fine. So every time I give that yes, patient is responded, but I give them a glitch kind of thing that maybe there is a chance the patient is in hospital. There may be chance of secondary pneumonia. There may be chance of secondary infection. So there is always a chance of deterioration until the patient reach home. Even after reaching home, the patient can have. And for to tackle this situation, even cardiac arrest, sometimes definitely I have to told like that probably the patient had an AMI or acute coronary syndrome, and that can happen in home also. So it's nothing in our home. And definitely what you have said, that you have to be very clear and empathetic. That is the first and foremost important thing. Now I'll move to Dr. Moitreyee again. Second case scenario. So a patient admitted with saphenous fracture underwent a successful OT. So the orthopedic doctor has told the patient relatives that the successful OT has been done, everything is fixed. But once the patient returned from OT to ICU or the HDU, the patient rapidly developed hypoxia and hypotension and went into cardiac arrest. So what important parameters you have to check for apart from the standard CPR, and how do you counsel the patient relative? Dr. Moitreyee?
Often come across, especially in large bone fractures. So the things that we have to be prepared for are, or which cause it, are responsible for causing sudden cardiac arrest in these patients. Most importantly, fat embolism. Secondly, pulmonary thromboembolism because of DVT. The less common causes could be a massive bleed which could be concealed. And since these patients are usually have comorbidities, we also have to look at the possibility of myocardial infarctions. Apart from the other 4Hs and 4Ts, So what are the additional measures in CPR that we have to take care of? Especially because there are no antidotes to fat embolism. If we suspect fat embolism in a patient, sudden hypoxia, sudden increase in heart rates, petechial rash may or may not be present. So we have to ensure that the patient is getting enough oxygen, 100% oxygen, fluids, and there's no specific antidote. We just wait and watch. If a massive P is suspected, then we have to act on our toes and ensure that the patient has access to thrombolysis. That could be life-saving in these scenarios. If we suspect a blood loss, if we suspect dehydration, hypovolemia, rapid correction of hypovolemia, and rapidly instituting, Paxil or blood transfusions, we have to be prepared for that. Especially when it comes to counseling relatives. Otherwise, a fracture, surgery for correction is uneventful. From the surgeon's point of view, they have done everything correctly. But then it is very essential to communicate before the surgery also that there could be a number of fatal complications that can occur, uncommon, but if they do, they can be possibly fatal. So this, like Dr. Abhishek Tandon has very rightly said, clarity is very important. Sometimes we may hope that nahi hona chahiye, may not happen, but then communicating that there is a possibility of a sudden complication which could be fatal is very, very important. If we preemptively counsel the family, then even they are prepared, and it becomes easy for us to, communicate such things.
True. Excellent, Dr. Moitreyee. Now, Dr. Ruby, so your case scenario would be a patient admitted with, road traffic accident and cardiac arrest. The patient reached the emergency room and there is a cardiac arrest. Roscoe achieved, the return of spontaneous circulation was achieved after CPR, but the patient suffered from severe hypoxic brain injury leading to brain death. So it is possible to donate organ even after cardiac arrest. So what would be your take and how do you counsel patients for organ donation? Dr. Ruby.
Yeah. So regarding organ donation, there are two types of organ donations basically. There is a donation after brain death or a neurological determination of death or a beating heart donation that we call it. That's the most common type that we do. So the patient is brain dead and then we can counsel them that there is no point in further, it's futile to do any more continuation of hospitalization or the life support, and he can benefit to many other people. That's how I would counsel for the organ donation. There is another method which is called as donation after a circulatory death. Now that you can classify it as uncontrolled or a controlled one. So the controlled one would be where you have a surgical team assembly before the planned withdrawal of a life-sustaining therapy happens. And once it is all planned and the patient's attenders have all consented, there is a withdrawal of the mechanical ventilation or the ECMO. And once criteria for cardiocirculatory death is met, death is determined, organ procurement happens. Why I bring this here is there is a classification called as Maastricht classification, which states certain scenarios. So the one is Maastricht classification 1 states that when a patient is dead on arrival, it's an uncontrolled situation of a DCD, the donation after circulatory death. So there you can only take tissue, nothing else. So here you have the fourth one states that there is a cardiac arrest in a brain dead donor. So that is a controlled situation where all organs can be taken except the heart. Sure. So there it's a brain dead patient. He has suffered a cardiac arrest so that the heart is not viable, rest everything you can take. This situation that you gave me, sir, here the cardiac arrest happens first, ROSC is achieved, then he suffers a severe hypoxic injury during the CPR and he is declared brain dead. So here you have to check the viability of the heart, and if it has recovered from the stress, it can be taken up if it is healthy. So whereas the other situation where a brain dead donor suffers a cardiac arrest, the heart is out of the list of transplantable organs.
True. So definitely we have to counsel, every time there is a brain death or definitely the this DCD, that is the donation after circulatory, and it's not so popular now, but it's coming in pipeline because the after donation following brain death, even Suppose in multi-specialty big hospitals, sometimes they're counseling. In medical college, they are continuously counseling, I think, if they are properly trained. But many doctors are not doing this. Okay, so not doing the proper counseling for organ donation. And even in India, so the chances, the transplantation rates are quite low. So that even in other countries also, but definitely we have to perform better. Okay, definitely we have to perform better. We have to counsel patients every time there is a possibility, there is brain death. Every time we have to counsel the patients for the organ donation, so that we can increase our organ transplantation rate. Okay, now I move to Dr. Tejasvi. So suppose a patient came to your emergency and you see there is no pulse, the patient is not respirating, there is no breath. Okay, so would you start CPR immediately, or would you check some parameters? Probably it's a broad death patient before starting CPR, and how do you counsel the patient? So these things happen actually in emergency.
Yeah, I
Dr.
think
Tejasvi.
most of the people think this is a very tricky and did we need to start CPR or not? But as per my experience, as per the AH and ILCO protocol says that you have to start the CPR immediately as soon as you get an unresponsive with no pulse. Don't hesitate to stop. Like should we do it not? A second of delayed in CPR can delay in mortality and morbidity. So it increases the mortality. So start the CPR at the earliest. But there are the few situations where patient might have a DNR, do not resuscitation order, which is an advanced directive. When the patient has that, if the relative shows the DNR, then we can start the stop the CPR because it's a patient wish. But that is happens only when it's a legal by the legal advisor from the court order. It is in India, it is very less, but in UK and US, it's more practiced. In India, it's more common is like the relative says that don't resuscitate. We take into the consideration in India the next of kin mainly, so we take the consideration of those people. And other situations where we stop CPR is when the rigor mortis is setting. The rigor mortis is setting when the 6 to 8 hours of death already happened. There can be a decomposition and dependent lividity. So in such situations, also we won't be able to do the CPR. So that's a clinical scenarios, but any patient who comes immediately, the starting of CPR is important. That will also give fetch off in front of the family members that we have done something. We know that the patient may not be able to survive if it's more than 30 minutes, but doing a CPR and showing the resuscitation efforts to the patient that we have done something is important.
Definitely. Even if the the cardiac arrest, witnessed cardiac arrest, or even they have taken, they've given some standard CPR, definitely have to start immediately. We should give them a chance to survive. Okay. Now we move to Dr. Vibhu again. So what is implied consent? Those two important questions. What is implied consent, and what is the duty to act?
Okay, so implied consent is basically when you have an emergency where the patient is kind of unresponsive, has been brought maybe from a roadside or has got unresponsive all of a sudden. It is legally assumed that they would want to, have the life-saving procedure or treatment, which is the CPR. So that's basically taken as an implied consent. And there's something called express consent too, where, you have a non-emergency setting where, the patient is kind of conscious and is having some kind of cardiac arrest or something, and he's still able to communicate to you. At that point, you have to take a consent. So, as Dr. Tejasvi said, you have to respect the patient's wish. So that thing probably doesn't really normally arise because it's there in the legalities. However, somebody who's having a cardiac arrest probably won't be able to give a consent at that point of time. So that is something, eventually it means that it's an implied consent. Another thing is about the duties to act. The duty to act, it basically applies to the healthcare professional or somebody with a legal obligation to give a CPR. Now, legal obligation is like those who are like the swimming lifesavers who are there at the swimming pools, or at certain places where you have the lifeguards. So they have a legal obligation. Now, in case you don't act, the failure to act can result in a criminal liability. So that can be put, earlier it was IPC 304A, but now it is under the 106 BNS. So now we need to be even more cautious because we need to understand as doctors, you can be put behind bars for 2 years So earlier it was, death due to negligence, which was not, putting as culpable homicide. So it was still with a fine you were being left, but now it can be put behind bars for about 2 years. So that is one thing which is there. Apart from that, you can be charged under professional misconduct or civil liability. Another one point I would like to put forward is that there was a case in 1989 where there was a landmark judgment by the Supreme Court, which is now the law of the land, that any doctor who is private or government has a duty to do whatever he can under the situation for the patient. That situation means that has to be a clinical setting. So if a patient is brought to you in your clinic, and even if you don't have the resources, you can't just check out the patient during that point of time, and you have to do the CPR, perform the CPR, do whatever best you can do with whatever things is available at your clinic, and then only you can refer or transfer the patient to the higher center. So this thing is again very, very important, because you must have seen a lot of times we have our clinics, somebody having a small clinic is having just a kind of an OPD, and a patient is brought to you. So at that point, you can't just take it, you just take it to the hospital. You have to do the CPR if required at that point of time, because that's a rule and the law in the country. So that's duty to act.
Okay, thank you, Dr. Vibhu. Now I move to Dr. Abhishek Tandon again. So there is a change. Initially there was ABC, that is airway, breathing and circulation. Now it is changed to CAB, that is circulation, breathing and airway. So why this change happened, Dr. Abhishek Tandon? Please your comment on that.
Yeah, so basically what was the rule of law was you first focus on the airway, then the breathing, and then the circulation. But in 2010, the American Heart Association realized something, and they realized that while the people were following this particular sequence of events, it was taking a delay of somewhere between 45 to 60 seconds while the chest compressions actually began. And we have a lot of data which now tells us that it is not the lack of oxygen, but the inability of the heart to pump the oxygen to the vital organs, which is actually detrimental. And this realization caused in the year 2010, the AHA to come up with a revised algorithm with the CAB, or the circulation, airway, and then the breathing, which ensures that the chest compressions are the first thing that a person does. And mind you, it also comes with a conditional recommendation that if you are alone and if you're performing a CPR and a rescue breath is something that you're unable to do, you should focus only on the chest compression. This is how vital a chest compression, again, mind you, a good quality chest compression is. And to emphasize the importance of that, the algorithm was changed.
Excellent. So again, Dr. Moitreyee, so what protocol do you follow in post-resuscitation? So a patient had a cardiac arrest, you have successfully resuscitated the patient, ROSCOX achieved. So now how you do monitor or any kind of protocol do you follow for the post-resuscitation patients? Dr. Moitreyee.
After successful resuscitation, now we have to maintain the circulation, stabilize the breathing, and prevent any secondary brain injury. These are the goals. And also, if there are any treatable causes, now we have to identify and treat the cause of the cardiac arrest so that it doesn't happen again. So when it comes to airway management and breathing, we have to secure an endotracheal tube, maintain a target SpO2 of around 94 to 98%, a target PaCO2 of 35 to 45 millimeter of mercury, and administer lung protective ventilation. Coming to circulation, maintaining a systolic blood pressure of more than equal to 100 millimeter of mercury, or a mean arterial pressure of more than 65, and then as needed fluids, vasopressors, inotropes, a continuous 12-lead ECG monitoring, and if there is any intervention that is required in the form of a percutaneous intervention or a CAG, then that has to be carried out. Coming to neurological care, we have to assess the motor responses of the person from time to time. And a very important thing is the targeted temperature management, because because any kind of fever is to be prevented. Hypothermia is extremely detrimental to the cerebral circulation and can cause irreversible damage. So it is better to maintain a temperature between 32 to 34 degrees Celsius, and it could be done by a number of things from outside the body or from inside the body, like a cove surface or using ECMOs, etc. Seizure monitoring, but because there has been some level of hypoxic brain damage, so seizure monitoring, we have to be prepared or in some cases, if we are sure that it is going to be there, we have to be, willing to prevent it as well. And in any case, excessive sedation is to be prevented, because otherwise we'll not be able to assess the motor responses properly. And other supports like correction of electrolyte imbalance, initiation of enteral nutrition as early as possible, and ensuring a good glycemic control. And if in some cases there has been, if there is any compromise of the renal function, we may also require renal replacement therapy. So these are the things that need to be ensured. And if there are any identifiable or reversible causes, then we get around to treating them as well.
So, Dr. Tejasvi, for you, the question is, how would you monitor, the CPR quality? So, do you believe there must be a CPR team or code blue team to be available in every hospital? And another important part is how important is the documentation. So you have done CPR, you have given adrenaline, amiodarone. So documentation from medical legal point of view, how is it important?
I think there are two questions. I'll divide into two.
CPR quality.
Yeah. So the CPR quality is most important, and how do you assess this? So we should have a time recorder, the person who records all the events. Okay. So he sees the quality of the CPR, whether the appropriate rate is happening, appropriate depth is happening, the recoil is there any interruptions, more interruptions there or not. So they'll check it. And other way is that there are two devices. One is ETCO2, where it monitors the CPR quality. If less than 10 or more than 20, the CPR quality will be assessed. And also the arterial pressure monitoring. If in hospital, if there's an arterial line already in situ and the monitoring is happening, that is also gives enough depth of CPR. And also the visual feedbacking device. There's a device which kept on the chest just before doing the compressions. So that will also give us the feedback. So whether the chest compressions are adequately delivered or not. So these are the important aspects where you can monitor the CPR quality. When it comes to the documentation, the real-time documentation is pretty important. If in hospital, if you are a good team, about 45, the person is recording the time, and if you have a checklist and record all as a chronological order, as from the arrival of the patient to the during resuscitation, every point need to be captured appropriately. If anything is missed, and that can be legally held responsible. So the doctor, I think there are a lot of cases happening recently, and they're showing that a lot of medical negligence are happening. That's because of there's no proper documentation. This is the documentation, the only thing where we can protect ourselves, that we have done so much, that we have identified the cardiac arrest, we have resuscitated, we have identified the reversible causes, we have treated the reversible causes. Despite our best efforts, still they couldn't be identified. And the similar way, we have to also document the counseling of the patient, what we have done to them, that we have updated the family members as well, and same thing has been documented in their own understandable language. Everything is documented, and that gives us the appropriate protection and the good protection to us in the court.
Definitely. Now we are not gods. If we save them, that's okay. But if we not save them, then we are villains. So
yes,
definitely the proper emphasis to be given on documentation. Okay. Now, Dr. Vibhu, for you, what is this Good Samaritan law in India?
So this Good Samaritan law in India came in 2016, where it protects the layperson or the bystanders who assist the accident victims or the unresponsive patients, those in emergency, by giving CPR, or at least bring them to the hospital or inform the ambulances or whatever. So they don't have any criminal or civil liability for helping in a good faith, and they have no obligations whatsoever to reveal the identity or even appear in the court. So this is something, it's like, because see, if what used to happen, in case you find a person who is lying on the roadside, you probably would walk off, because nobody wants to get into the police trap, and nobody wants to get into the court and all. So it was to protect those people. This was brought in, and it was issued by the Ministry of Road Transport and Highways, mainly for the road traffic accident victims, and was upheld by the Supreme Court. Another thing is, it is not applicable to medical professionals in a clinical settings. So we are not safe if we say we always act in a good faith, but we don't get any protection as far as this law is concerned inside our hospitals.
Okay. Okay. Okay.
But if we are going to work as a layman, if we are doing with our expertise, if we are doing it on the roadside and all, we get all the protection.
Okay. Okay. So I think Dr. Ruby. So do you think it is mandatory to incorporate basic CPR learning in school syllabus, Dr. Ruby?
The answer to that is a big yes. So there's a paper in AHA journal stating that kids save lives. It was published in 2023 regarding basic life support education for school children. So this out of hospital cardiac arrest has an incidence of around 67 to 170 per 1 lakh inhabitants, making that a very leading cause of deaths worldwide. So the survival rates has been noted to be around 2 to 20%, and it's particularly low when they do not receive an immediate bystander response. And cardiac arrest causes systemic ischemia, resulting in an immediate damage, as we saw, to the critical tissue. And brain, being most vulnerable, gets damaged within 5 minutes. And the most effective way how we can prevent that cell death is early restoration of circulation and oxygen supply, which is the purpose of this CPR. Yes, sir.
Okay.
I would like to add a point. I would like to
Yes,
add a
yes,
point
yes.
because see, the school question which you asked, being a pediatrician, I mean, almost like for last 20 years, I've been hearing that it would be incorporated in the school curricula, and at least the BLS would be taught to the kids. I mean, it's been 20 years. It's not been a small time period. And till date, what it was mentioned in one of the lectures also earlier on, where we have come to know that even 40% of the doctors don't know how to do the basic CPR. Let's be very honest, as doctors, we don't know how to do the CPR. And for the kids, I think unless the government gets serious, so this thing, I think we should, as CCI, probably a letter can go on to the government to incorporate the basic BLS. Actually, BLS is no big deal, and you don't need too much of a time from the school or anything. It's just a 1 day kind of a job which can be done. And maybe for different sections, even if it's done over a period of 6-7 days, I think every hospital would be ready to do it, even free of cost. So it's just getting it incorporated into the system is important. Otherwise, everything is not difficult. Anything is not difficult. Sorry.
Yeah.
Yes,
So
yes,
the
yes.
check, call, and compress algorithm is what the kids should be taught. So it's been seen that even young children from 4 years, if you train them well, they are able to pick up the first links of a chain of survival. And by 10 to 12 years, if you teach them on mannequins, they are able to reach that effective chest compression. So school teachers are the first providers. If we do that, if you're able to do that, we'll be, training a whole generation out there.
I think I'll take this opportunity for just to.
Yes, yes.
The last year we had 100 years of AHA in Hyderabad, where we have trained more than 10,000 school students in Hyderabad.
Excellent.
Yeah.
Excellent.
This is what I also wanted to say is that you just mentioned that a letter, Dr. Vibhu just mentioned that a letter can go from CCI per se to the authorities. Why can't we do this? That as CCI, we have representatives in almost every city. If every pulmonologist takes this initiative to at least teach basics of BLS to the schools that are in his or her vicinity, we can start solving this problem and not wait for the authorities to act upon it. Just a food for thought.
Yes, yes, no, definitely. So basically, see the whole, the concept of this, these webinars, that why CPR is so important. Definitely, out of hospital cardiac arrest, everybody should. So we want a generation where everybody should learn about the basic CPR. So school is the thing. Say, suppose you can do it in shopping malls, you can do it in gym centers. That is okay. But the school is the one thing
I
where the
think,
future generation have.
so
Future
Dr.
generation.
Tandon, what you said, as a pulmonologist, we can go and go to the different schools. Believe me, the schools, I mean, my kid's school will take me seriously, but the other schools won't take me seriously. Let me be very honest on that. So until unless the onus is put on the school that, okay, you need to teach your students should know BLS, the schools will never be, satisfied or happy or welcoming. It's very easy to say, okay, I'll go and speak about it. So if I have actually, to be very honest, I have written to a few schools and only about 2 schools agreed to it. So I had a lecture on puberty thing and only 2 schools appeared to be happy about it. Otherwise, they say, okay, we'll let you know. Because see, the schools have their own schedule, their own curriculum. They already have too many activities. So until unless this gets incorporated, nothing is going to happen.
Even ICCM Kolkata, that is Indian Society of Critical Care Medicine, Kolkata is now doing, some, this kind of BLSS training in school. They have, I think 2-3 schools have been already done, the big schools. Okay. But definitely from our side, you have to take initiative. From the government side, it should come. And I definitely can tell the CCI authority to think about that, to incorporate this BLS protocol, basic CPR protocol in, the school syllabus. Okay. So my next
I have
question.
one
Yes.
point alone to
Okay,
add
yes,
on.
yes, ma'am. Yes,
So
ma'am.
an age-appropriate social media tool can be
Yes.
incorporated. Like if we could make a video with cartoons which can, easily relate to the kids. And if we are not able to reach up to them, maybe this social media tool will definitely reach out to many kids out there who are watching it. So that could be one way we could reach out to them and educate them.
Excellent, excellent. So Dr. Tandon has told us about, the Lazarus phenomena. So I'll go to him. Dr. Tandon, could Lazarus syndrome be underreported due to lack of awareness or documentation?
So the
Dr. Abhishek.
answer is a resounding yes. I was surprised while I was preparing for this lecture. I just typed in the keywords Lazarus syndrome in India, and there have absolutely been almost no cases that have been reported in a good scientific journal, but the media is flooded with it. So what happens is there have been reports from almost every part of the country where a patient being pronounced dead goes home, goes to the mortuary, or is in the ward or in the ICU, and then regains signs of life. And the onus is always put upon the doctor, and it's labeled as a medical negligence. I definitely feel that the awareness is lacking. I definitely feel that the people who are aware are afraid to report it because they would be labeled as being negligent. And this is something that needs to be created awareness on. And this is something that actually needs reporting so that many such cases, which are actually blamed by the media on the doctors as being negligent, are actually rectified and are attributed to Lazarus syndrome.
Excellent, excellent, excellent. So next, Dr. Moitreyee. So what protocol should be followed to confirm death after failed resuscitation, considering this possibility of Lazarus phenomenon? And how long should clinician monitor a patient after cessation of CPR before declaring death?
There is ideally, 10 minutes is to be, we have to wait before declaring a patient as dead after a failed CPR. But there are also exceptions. Okay, there are certain exceptions, like hypothermia. It's said that it's not dead until it's warm and dead, because hypothermia may also mimic certain circulatory failures. So we have to wait, ensure that the core body temperature is above 36 degrees Celsius, and then declare a patient dead, if at all. And certain drugs like sedatives, opioids, anesthetic agents, and tricyclic antidepressants may have a sedative or deep sedative effect, which may mimic a coma or death. So if possible, if available, naloxone as an antidote should be given. And if not, you have to wait. Electrolyte and metabolic disturbances sometimes may also require some time to recover. So we have to give them a good rundown time. And pediatric cases, especially neonates, have a different physiology. So they may respond to CPR or medicines or certain corrections in a delayed way. So we have to wait for more than 10 minutes in these patients. And also some special situations like drowning. Drowning in very cold water may also mimic hypothermia. So we have to ensure that the core body temperature is raised. And in pregnancy, it is advisable to continue resuscitation, because that way we may extend the resuscitative efforts into saving the fetus as well. So these are the special circumstances. Otherwise, considering Lazarus, we have to ideally wait for at least 10 minutes before declaring death. But then again, the point of ethical conflict comes that when is the exact time of death?
Oh, I'll come to that. Okay. Now,
I'll just
Dr.
add a
Dubey.
point to this.
Yes, yes, sir. Yes, sir. Yes, sir.
Such scenarios, if we can allow the attenders to witness the resuscitation, that will help us a bit in declaring also. Even if the patient wakes up, still we can declare that we have showed you the flat line.
Yes, yes, yes. Dr. Ruby, how should resuscitation team manage the emotional clinical impact when a patient revives unexpectedly, and what medical legal consequences can arise thereafter? Dr. Ruby.
Yeah, sir. So, like all the speakers and panelists told, this is a medical enigma. So,
Yes.
how long do we wait? 10 minutes, or there was a case scenario where he came back after waiting for 180 minutes. So, that is not very much clear. So, we need to have guidelines on that, more research on that. But yes, it's going to be psychologically draining both for the doctors and the bystanders. So, the doctors might go into a guilt trip. So, did I do enough? Or was the CPR enough? Or did I make any mistakes? Whereas the bystanders would be think they would have already got into the grief of losing somebody and then getting him back, and then again they would think whether it was a negligence. So having an effective and honest communication with the bystander while the CPR is on is the key, I believe. So when a person or the team is doing the CPR, there should be somebody who should be going out, because there will be attenders, bystanders who will be waiting for the news. So instead of going and telling that, okay, yes, we are starting the CPR, and then finally at the end of it going and giving the last news, somebody should be coming in between and giving them the news that, yes, this is going on, this is what we are seeing, and we are not able to. So multiple communications if it happens, so they would know that, yes, we are doing our best. Controversies and ethical considerations here is verification of death, as in whether we have to definitely ensure, like Dr. Moitreyee told, ensure they are indeed dead before we go and terminate our efforts. And there should be an informed consent from the attenders for this resuscitative efforts. Seminars and webinars like this will increase the public awareness regarding a Lazarus syndrome, so they'll be aware and well prepared about outcomes of a resuscitation. So it can be the terminal outcome, or they can be a rare event of Lazarus syndrome as well. There is something else of quality of life after this syndrome. There was a case study of cases from 2015 till 22, where the survival of those cases ranged from 3 minutes to 5 months.
Yes.
So we do not know how is their quality of life, whether there is severe neurological deficit or severe disability. And so you definitely have to wait for declaring it. And then the time of death is a doubtful question. This is definitely a potential case for medico-legal negligence because of lack of awareness about the syndrome. So how do we prepare for that is having documentation, like Dr. Tandon had told, right? So there should be documentation, proper documentation. And we should have an asystole shown in the ECG in the intermittent time before we declare, and then this comes back, so that we have evidence in the court of law to protect us. That yes, there was an asystole, so we are not wrong in declaring a death with an asystole. And if it comes back, then we tell them that yes, this is a rare phenomenon and we are lucky.
Yes, yes, definitely. So two important point is that definitely you have to increase the awareness, and definitely this is a rare thing. So if that things happen, so you have to be aware of this Lazarus phenomenon, and you have to explain that to patient relatives that there are certain papers or cases you can see that this kind of things can happen, and there is a medical some medical cause for that, definitely. Now definitely, Dr. Tejasvi, should there be standardized guideline internationally for post CPR observation time before pronouncing death? And how can hospital protect both clinicians and families from the distress or this legal dispute in such rare scenarios? Dr. Tejasvi, most important question from Lazarus syndrome.
I think this is the most important aspect,
Yes.
how to declare. There is, as per the American Heart Association, European guidelines, or AICOR, there is guidelines for CPR, but there is no guidelines post CPR as such. It says that no, actually, there's no observation time before pronouncing death. If you have done adequate CPR, it is witnessed or unwitnessed, you don't have any reversible causes to see to any chance of survival. If ECG shows the flat line, then it can declare death. So you don't have any other further aspects to consider. And your E2CO2 also shows the less than 10 millimeters of mercury as well. So this is that. And only where you consider the longer resuscitation times, I mean, usually 20 to 30 minutes, we consider resuscitation time if it's unwitnessed. If it's a witnessed, or if in case of hypothermia, and Dr. Moitreyee already said in the poisoning situations, and the pediatric cases and the drowning, the resuscitation might go up to an hour or 2 hours. So we should consider the resuscitation for the prolonged in only the such scenarios. Otherwise, you can declare, depends on your ECG as well as the no reversible causes identified. And as per the legal considerations, always involve the family, next to kin mainly, who are the main person during resuscitation, and show them and make them witness the resuscitation. And post resuscitation, when you're declaring, you need to do the break bad news in such a way that make them sit in an ideal room, call most of the family members who are responsible for taking care of the patient, make them sit, gather the information, what happened before these, and gather information like how the resuscitation happened, explain them appropriately. You need to be honest, empathetic, and you need to be clear and concise when you're explaining to them. And you need to break the bad news in an empathetic way, allow family to take their time and answer each and every question in a precise manner, and don't use any medical jargons. When you start using the medical jargons, that then it's considered shows that you're hiding something. So don't use any medical jargons. And you need to create a standard protocols in the hospital. There are certain local protocols at different institutes. So you need to, using the international guidelines, adapt those things into the standard medical guidelines and use them, the guidelines. And if you have a checklist based resuscitation checklist, and you keep that resuscitation checklist also, what everything in the chronological order. So that will also gives us protection in the documentation as well. So appropriate documentation also gives in good. And regarding the police intubation also, whether we need to do medical legal MLC for all the broad cases, answer is still debatable, but we don't do all MLCs for all broad dead. Until unless you don't having any cause of death, you think any suspicious that the death happened to something else. It can be poisoning, it can be a road traffic accident. In such scenarios, you do the MLC, but you don't do for the chronic cases like they have already comorbids. So that can be cause of death for that, but you don't need a broad death for that. So you need to create a broad death certificate. You need to have a death certificate for that. So two different certificates you need to create, and you need to have a protocols for those two certifications as well.
So one thing I would like to add to your thing that you said that you can have the relatives along when you are doing the resuscitation. It's easier to do it in the adults, not in case of the children. At least I can tell you that, because at that point of time, when you're doing a resuscitation and the parents are around, they go crazy. Yeah. And I've had instances where I have done resuscitations in the wards where it's like government hospital is like an open scenario and you're doing the thing. And eventually the parents got agitated that it is because you pressed the chest so badly that the patient died. So those kind of issues. And I mean, I don't disagree with a few things. Like we tend to break the rib cage also at times. That things may happen. And with children, it is more common. So I think it's a very, very gray kind of an area where you have the parents along when you're doing the resuscitation. I think you need to see the situation and then decide on what exactly you need to do at that
in such scenarios, we can include the social worker so that they will help us in calming them.
I mean, it's not always available. That's the point.
I think if it's available, then use of those.
Yes, definitely,
yes, definitely. That's a good thing, because there's one person apart from the resuscitation team. Someone has to keep talking to them. If in case there's a lot of the most of the mother and father, usually they'll be tense and stressed out, and they won't be able to give us time, and sometimes they'll interrupt our resuscitation also. So one person taking care of them, talking to them, either it can be a doctor, it can be a social worker. So that will be helpful. Or it can be a nurse as well.
Yes. So basically, definitely we need more and more research on this Lazarus syndrome, and we have to identify what is actually happening. Now, my last question of the panel discussion would be Dr. Vibhu. So what is the status of this DNR, do not resuscitate, and euthanasia in India? Dr. Vibhu.
So it's still very much a gray area in the Indian law. The Supreme Court is very clear. In 2018, they said that the legality of passive euthanasia and living wills can be done under strict guidelines. So you need to have a board which allows the passive euthanasia. and you need to have living wills which have to be documented, and it has to be registered with the judicial magistrate, where you have to, before you go for a DNR. So in practicality, if you see, as of right now, DNR implementation is a very rare and complex thing, at least in our country, because it's not easy. When you are doing it in our country, it doesn't only involve the individual. So you have four children, all four going to have different opinions, and probably you'll see all four of them together at that point of time, but half hour after death they'll be all fighting in the court for the property and everything. So you have to be, you don't want to be a part of their mess. So I think DNR still remains a very gray area. So until unless it's a registered thing with the magistrate, and you have the registered thing with you, and you have people from the family, even if one person out of say 3-4 people who are the first relatives, say there are four children, even if one say that you should resuscitate, I think it's better to go for resuscitation, because if you do not, believe me, you resuscitate, you will not be in trouble if once you are in the court. But if you do not resuscitate, you are definitely a part of the criminal conspiracy to kill the patient.
Yes, yes, yes. So,
And even if the patient is 120 years old, believe doctor is always criminal.
so no, there are lots of things,
Doctor is criminal until unless proved otherwise.
So there are so many things. Even I have seen DNE. DNE means do not escalate. Okay, DNI, do not intubate. DNR, do not. So there is so kind of, but these are not actually what you have said. That's legally valid, and this is some kind of mutual understanding between the doctor and the patient relatives. But what you have said, that every first hand patient relatives to be that nobody from the relative is not maintaining that, no, I should go for the CPR, or you can do this. So there is a mutual some kind of thing between all the relatives and you, then you can think of that. But the point is that legally it is not valid, and definitely active euthanasia is not valid in India. But you can do passive euthanasia, means where you are actually withdrawing the supports.
But for that also, the way I think most of us must have seen that the patient is like that. Okay, fine. There is nothing that's brain dead. You can remove the support and everything. But believe me, if you go by the legality, you need to consult. You do need to have a medical board which approves.
Medical board, yes.
Okay, this is like the brain dead, and now you can remove. So, and that also came in 2018. Before that, it was not.
Before that, it was not. Yes. You have to do a medical board, definitely. So from the chat box, I got only one question. Dr. Probin Vatia from Delhi. So if tertiary, he is asking that if tertiary care is available far away, for how much time manual CPR to be given is legally safe? So, okay. Dr. Tejasvi,
I think I'll
can answer that question.
Yeah, I think there is no time limit as per se. If it's witnessed cardiac arrest, doing a CPR about 30 minutes would be ideal. Ruling out all the reversible causes. And if in case of a drowning, a poisoning, or a hypothermia, or in pediatric cases, doing a resuscitation for about an hour or 2 hours would be an ideal situation, unless you get ruling out the reversible causes.
Yes. So excellent discussion by all of our panelists, and I think it's almost it's almost 9:30. So just let me check, is there any other question in the chat box? Otherwise, we're going to conclude the session. No, I think there is no any other questions. So definitely thank you everybody. Thank you Dr. Tandon. Thank you Dr. Moitreyee. Thank you Dr. Ruby, and thank you Dr. Tejasvi and Dr. Vibhu for your excellent deliberation on the question panels. Thank you CCI team, and again a heartful welcome for everybody for tomorrow's CCI Con, which is starting from 22 tomorrow, and it will go until 22, 23, 24 at that Sunday. Everybody is warmly welcome in Kolkata, and thank you. Now I conclude the session.
Thank you.
Thank you very much.